concerning the update survival of the Profile 1014 study, it is interesting to see that with a very long-term follow-up, there is a small increase in survival, which is actually seen from the beginning of the trial on the Crizotinib arm as compared to a chemotherapy, with a hazard ratio of about 0.7, but not being clinically significant because the p-value was in the range of 0.09. However, when you do the analysis accounting for crossover, you realize that it may happen that those patients that actually are not crossing over, there were 15% in this trial, actually they may have a jeopardized survival. And this is an important message. Second message in this trial, it looks like the more the treatments the patient is exposed to, most likely the survival would be enlarged. Of course, this is not a clear-cut conclusion, but this is my impression on the context of the disease and in other trials. Concerning the ALEX trials, it's been shown very clearly in this sub-analysis that Alectinib is much better as compared to Crizotinib to control CNS disease. Not only with those that already had metastatic disease in the brain at the time of diagnosis, but also for those without metastasis in the brain at the time of entering the study. In both cases, the hazard ratio for PFS was clearly in favor for Alectinib. The question is if the drug is much better than Crizotinib in controlling the systemic disease, and I think that analysis should be done censoring patients when they have a CNS metastasis, which is the more frequent event. In any case, it is my take, given the robust PFS data, response rate, particularly the data on CNS, which is a very important issue because it's very important for patients not only to be alive, but it's important to be alive without CNS disease, or the later the better. So you delayed living with CNS disease, but also you delay the treatment with radiation therapy, which is important. So considering all these factors, but also the fact that safety profile is quite favorable, I would say that I don't know at the present time the best sequence for a given patient with an ALK metastatic disease. But what I know is that the first treatment very likely to be Alectinib.